with fillers, right? And have you been injecting fillers for a long period of time? Okay, so I would like you to do what I tell you, and please, whatever you have of experience or information previously, just throw it away in the nearest trash bin. I'm gonna reset your minds, okay, in a different level. I'm gonna restart, because it's like doing a restart, okay? Okay, so today we're gonna talk about some things, some basic things in filler injections, and then we're gonna go up a little bit by bit until we go to the advanced level. So I always like to start basically, and you know that there are three types of injectables: hyaluronic acid, which is the main things we use, calcium hydroxyapatite, and polylactic acid fillers. There is permanent fillers, but it's rarely used, and it has some specific indications. If anyone cannot understand my English at any time, just please tell me, and I'll translate that into Arabic. Okay. Okay. So you're at your office, you're at your clinic, and mostly women come seeking for beauty, and when they come, they're asking for this, especially those who want filler injections. They want an oval or pear-shaped face, because you don't want a rounded face or a square face. You want an oval shape. This is more feminine and it's more beautiful. You have the OG curve. You want full lips. They want high cheekbones, straight small nose. They want a defined jawline and a sharp full chin. Before we move on, Dr. Amay, do you have any idea what the OG curve is?
Not a very specific, but I know that it's the curve here that makes the cheeks more with. I'd like to know more from
Okay. Does anyone know anything about the OG curve? Do you know where it started off originally? It's architecture. It's not actually related to medicine. It's something architecture. Okay? We're going to talk about this now. So, if you ever go to IMCAS, like international conferences, you need some coffee? Okay. Okay. Right, so if you ever go to international conferences, you have what we call, and you hear sometimes what we call the phi theory, or sometimes they call it the golden ratio. Now the phi theory is the length of the face in proportion to the width of the face. I don't know if this is the pointer or not. Right, so anyway, pointer is not working. So the length of the face to the width of the face, it's usually 1 to 1.618, and this is what we call the golden ratio. So you should have more length of the face than width. That's what gives us triangular, pear-shaped, oval-shaped face, right? So the phi phenomena, or the golden ratio, is 1 to 1.618. And we're gonna apply this for everything as well. So now, it's just the basic starting point. Where do you measure the 1 so that the 1.618 is equivalent to that? And there's a special instrument, I'm gonna show it to you now. It's always the intercanthal distance. So I don't care, my intercanthal distance might be different than yours, than Dr. Taif. So whatever it is, when you get the intercanthal distance, the other side should be 1.618, okay? And the intercanthal distance, supposedly, should be equal to the distance between both eyebrows, the distance of the medial 2/3 of the eyebrow to the lateral 1/3. It's the distance between both ala of the nose. It's the distance from the lower lip to the chin, and it's the distance in the front view from the angle of the mouth to the side of the face. Okay? And that's why even in surgery, if I want to do a rhinoplasty and I say, does she have a broad nose or does she have a thin nose? Do I need to do some ala reduction as a surgeon? I measure the distance from the lateral ala to the medial canthus. And if the ala is protruding beyond that, it should be equal to the intercanthal distance. So if it's protruding, then she needs some ala reduction. She needs to have her nose thinner, okay? So this is just one of the assessment points, because you always have to do assessments before you do the procedure itself. And assessment is really vital and crucial. It's even more important than doing the thing itself. So as you grow older, you get more experience. Maybe someone who's younger than you, he will inject more frequently than you do, he will do it faster, etc. But what makes you different with your experience is you decide what to be done here and what to be done there, right? The decision is very important. Right, so we go back. So now we go back to the longitudinal axis of the face. And here we are measuring the length of the nose. Okay? So this longitudinal length of the nose should be equivalent to the eyebrows up to the anterior hairline. It should be from the medial canthus to the side of the face in the front view. It should be the distance between both angles of the mouth, and it should be the distance, or almost equal to the distance, from the upper lip, now not the lower lip, down to the chin. Okay? Okay. So, there is something that we call the swift point. The swift point is the highest point of the cheek. And it is different from males than females. So if you wanted to determine the most projecting point of the cheek, because this is a reference point, we are going to mark the malar fat pad. This is a very important point we're going to talk about now. And it also marks the entry point if you're injecting using a cannula. So the swift point from males and females are different. Let's look at how you determine the swift point in females first, and if you can get hold of this instrument, which is called the phi instrument, measuring the golden ratio, it will be of benefit. So you start from the lateral orbital rim to the corner of the mouth, and then the upper tragus. This is the tragus, this is the upper part, this is the lower part, right? So you go from the upper tragus to the corner of the mouth, lateral orbital margin.
Go straight down.
You go from the upper tragus then to the ala of the nose. For females, yes.
To our upper tragus.
Yes, he's a male, but he's demonstrating this for females.
This should be the intersection right here, and we can confirm that.
I'll play it again for you. Don't worry. I'm here to teach you everything and take your time. Good morning. You are Dr. Ariba from Pakistan. And what's your specialty?
I'm a GP.
Aesthetics, okay. So I'm going to explain this. Now, this part of the ear is called the tragus. This is the upper tragus, and this is the lower tragus, right? So, have you heard these informations before? Yes?
We did, but we don't remember.
So then how do you work?
We will.
How do you work then when you are forgetting the
Well,
basics?
we do it. I mean, I'm not doing very frequently, and that's why
Well, you will be doing, inshallah, after this course. And you will remember it, right? Like I said, I want you to have amnesia with all the previous knowledge. Something new. Right, let's go. So, you start from the lateral orbital rim to the angle of the mouth, upper tragus to the angle of the mouth, then you connect those two lines. Then, from the upper tragus again to the ala of the nose.
Swiss point. So what we do is we go straight down,
Upper tragus,
and we make another intersection from here.
the alar groove, see, like I said, to the upper tragus. And
This
where
should
they
be the
intersect
intersection
here, this
right
is
here.
supposed to be the swift
Confirm
point
that
in
by
women.
using
See, this is the instrument. So you get the intercanthal distance. The other side is bigger, so it's 1 to 1.618. So when you get from the medial canthus, see, it should stop exactly where you have done. So if you don't have this instrument, you can do these drawings. Now, look at the man now. You connect the lower tragus to the corner of the mouth. Mid-pupillary line to the corner of the mouth. Then you do a line that crosses them equally. So lower tragus to the angle of the mouth, mid-pupillary line to the angle of the mouth, then you dissect them in half.
intercanthal distance,
Again, intercanthal distance,
and that's going to be 1, and the 1.618 should
and
be
the
exactly
1.618, see,
length from
should be that
our
length.
line here.
Then you divide it in the other side. The 1 again,
Go down,
see,
and boom. Right there. And that is the apex for men.
and this is the apex for men. So it's in a slightly different plane and slightly lower plane. Why? Because when we talk about the OG curve, I'm going to tell you how different it is. Okay? Have you recorded that? Okay. So how do you classify hyaluronic acid fillers, which are the most common? You classify them according to something called the G prime. Sometimes you just say it's the G of a filler. So what difference is it, a high G prime or a low G prime? It differs in the duration it will last in someone's body or face when you inject it, and the effect it will do, and where you need to inject each filler individually, right? So the G prime is three things: cross-linking of the filler, it's the concentration of hyaluronic acid per 1 ml in milligrams per ml, and it's the particle size, right? So cross-linking is the bonds of the filler, how close they are bonded together. And the more they are bonded together, the more they take time to start disintegrating or breaking, so they last longer. The more concentration it is, the more time it takes to dissolve, so it lasts longer. Some fillers will last for about 4 to 5 months, others will take up to 10 to 12 months. And then the particle size, because you do have body fillers and you have face fillers. So face fillers are usually somewhere between 150 and 250 micromoles. That's micro M, right? So it's this Latin sign, micromoles. So it means it's a small particle size. But you have body fillers from 350 to 500 micromoles. Okay? So it's a bigger particle size. Thus, it has a higher G prime. Okay, there is also something called the elasticity and plasticity of fillers. Elasticity is how elastic it is. So when you inject something, it doesn't become stiff. It moves flexibly with the face so that you have a natural looking contour of the face. You want to inject someone that looks artificial. And plasticity is how tough it is. So you don't want to inject something that breaks down in a few weeks. You want something that lasts, that withstands what we call the shearing forces. So if you take a look at this graph, we have, for instance, Juvederm, which is quite popular. Everyone knows about Juvederm. If you see Juvederm Voluma, for example, which is one of the high concentrations, it's got a G prime of 274. You got something like Radiesse, it has a G prime of 554. You got something like Radiesse, this is Radiesse Plus, this is a different form. You got Restylane Perlane 531, it's much bigger. You got Radiesse or Restylane Sub-Q, it goes up to 1407 G prime. So although Juvederm has a lot of publicity in the aesthetic field, it still has a low G prime. There are other products that have a high G prime, so they supposedly will last longer. But
if G prime is higher, is better or no?
it's according to what you need to inject. For instance, if you want to inject fine lines, if you want to inject the lips or nasolabial folds, are you going to use the same as if you want to do volume to the cheeks? Then if you want to do volume to the cheeks, you put something with a high G prime. Because if you do inject something with a low G prime, she looks very beautiful when she leaves your office. And you take the photos, you post them on Instagram, and then 3 weeks later she comes back and says, "Where is my filler? It's gone." You know why? Because you have injected something with a low G prime. Okay. And let me ask you this, and it's going to be shown in the coming slides. Our face has a lot of fat compartments. Okay? We have the superficial and we have the deep fat compartments. And what happens as we grow older is two things. Our fat compartments, number one, become ptotic, they go down by gravity, and they atrophy. So they become less in volume and they just fall down. So it's ptotic and it becomes atrophic. So, Dr. Ariba, do you think the superficial fat compartments, there's superficial and there's deep, do they toes more or do they atrophy more?
They do more. With the aging, they
And the
sag.
deep ones?
Deep ones more. Medial soft and lateral.
And the deep ones, do they atrophy or sag?
sag.
And the superficial, they sag as well.
The superficial is atrophied,
Okay?
and deep
See,
ones
I got you
sag.
confused, huh?
Yeah.
Yeah,
Mostly
okay.
I've read
So
the articles.
you're almost close now. The superficial fat compartments, they are above the facial muscles, what we call the mimetic muscles, because they give expressions. So as long as they are above the muscles, when the muscles contract, they just glide over the muscles. So what happens to the superficial fat compartments is they become ptotic more. That's why when you need to do lifting of the superficial fat compartments, use threads in the superficial space. You don't go deep next to the muscles and nerves. It's going to be very painful and it's going to be very complicated. But what happens is the deep fat compartment are underneath the muscle. So as long as you're talking, you're chewing, you're yawning, it's compressing those fat compartments against the bone. So they atrophy more. Okay? Again, back. So something with a high G. Oh, I forgot to ask you my question. So, I've changed the way I inject for the past, 10 years, and now with fillers, except in specific areas, I go deep to the bone and inject. But some of you are still afraid to go deep to the bone. There are some critical vessels or nerves. I'd like to do it a little bit superficial. So if you want to do it superficial, you do something with a high G prime or something with a low G prime.
Low G.
Perfect. All of you are wrong. See, I told you. I'm gonna make a brainwash. So if you want to inject superficially, then you go to something with a high G prime. Why? Because it's fixed. It doesn't move easily. And I'll prove it to you. If you do something with a low G prime, not only does it disappear quickly, then you get your clients sometimes say, "Doctor, I feel that the filler has gone somewhere else. It has dropped. It's a low G prime, it's superficial, it's moving and becoming ptotic as facial muscles," and I've heard this a lot. You do something, I feel the fillers have gone here. I feel the fillers have gone from my nasal folds upwards. Haven't you heard this?
And I soft filler. Yeah.
It moves.
It moves.
So if you want to do superficially, you do high G prime in small amounts. Okay? See, and I'm not trying to force you to believe anything. I'm just proving it by your clinical experience. You do a filler, a low G prime, superficially, then she comes and says it's either gone or it has moved. Haven't you heard this? Especially in the lips. The filler has gone up, nasolabial folds. I feel the fillers are now here. And she always points to this area. I injected the lines. Why did the filler move up here? So this is the area that's swollen. I feel the fillers are here. Doctor, feel them. Yes, of course. It's moving all the time. And it's a low G prime. You're forcing the fillers, which is not as thick, to just disperse. And you know why? Because this is something that has a low G prime. It's more fluid, and you can inject it with a needle. But something with a high G prime, it's more solid. You might need a cannula to do this. So this will stay in place. This will be dispersed all over.
If we escape from injected deep in the chip,
Yes?
we use superficial, we use high GP.
Yes. I use a high G prime and I go deep to the bone. If you want to do something with a low G prime, just spread it all over so it gives you just a little bit of, tension to the skin. It gives you a little bit of rejuvenation, but it will not do much with contouring the face. Again, something with a low G prime has an initial shape. And then this is what we call the dynamic shearing forces. Starting from, you are compressing the filler outside the needle with the plunger. Then it goes out through this thin needle or through a cannula. So you're forcing it out the syringe. And this is shearing forces. Then it's placed underneath the skin. We're talking, we're putting in hands like this, you're sleeping. This is shearing forces. Something with a low G prime, when it's deformed, it never returns back to its original shape. But something with a high G prime, it tends to keep its original shape. That's why I said, if you inject this, it stays. She has good cheek volume, she has good cheek plumbing, and then she comes and said, well, I did this a few months ago and I still look nice. You do something with a low G prime, she comes back a month later and she says, it's as if I haven't injected anything. Where's my filler? I want my money back. You don't want to pay money back, right? Okay, so I'm giving you an example like this. So you have what we call the family of Juvederm. You have something like Volite, and it says it stays for about 3 to 6 months. Volbella stays more up to 9 months, even up to Volux goes up to 2 years, 12, 24 months. And now you have an idea what we mean by this, that this is something that has a low G prime, and this is something that has a high G prime. So I probably inject this something like rejuvenation, something that doesn't need a high G prime like the tear trough area, but I go deep and superficial. But if I want to do contouring to the cheeks, to the chin, jawline, etc., I go something like the Voluma or Volux with a high G prime, because I'm going to inject it over the bone, and I'm going to do reshaping of the face. Okay? Okay?
So, do you mean that you're going to use the low G prime only for like superficial touch-ups, and everywhere else you're using high G prime?
I use low G prime in areas like neck creases. You don't want something that will form nodules. In the nose, in the lips. These are areas where you don't need that much of a density. And you know, when I do a lip fillers, for example, do you know how much I use from the syringe? About, huh?
0.5.
I go maximum. I go for about 0.3 or 0.4, and I've done the lips. Yeah, I have a lot of clients coming over to my office and say she had 2 or 3 injections of fillers for her lips, and she's still not satisfied. And I go for about 0.4, 0.5. The maximum I've ever done was 0.6. And you can have, yeah, for both lips.
Both lip?
Yeah.
But with the juvenile, it's
Yeah, I know it's not that profitable for you, but the patient will trust you and she will come again. Hmm?
After how
No?
much?
So if you inject half a syringe and tell her you have good looking lips, take the rest of the syringe and come back about 6 months later, she will say, you ripped me off, I'm not coming back. Or is she going to trust you? She's not going to trust you? So if you do 2 or 3 injections, she will trust you. Really?
It depends on the region.
Yeah.
In Arabic patient and Iranian patient want a lot of
Right. So you can do this with 1 ml.
Usually with
One cc is okay.
No?
1 cc is okay.
I can do I do Russian lips with 0.6 and they last.
Russian lips.
Yeah.
With
With 0.6.
With 0.6.
0.6. Not 1.0.6. Huh?
أكيد حكنا قبل.
No.
There is
No.
injection.
No, no, no.
If you're-
higher gibran than which we use maybe.
After how many days we can inject it again?
2 weeks.
2 weeks?
If you need to add up.
More
2 weeks.
volume?
تخيلي العيانة مش هتصدقه لو حقن لها نص حقنة وقال لها وفر لها. لازم يديها 3-4 حقن. I'd love those clients. لا we don't have them in Egypt.
اي والله يعني ما كان.
In Egypt, you know, women come to my office and say, I want to do my whole face with 1 ml.
اي هذا اوكي بس الشفايف لا.
يعني الوش 1 ml okay.
أوكي.
لكن
إي-
the lips no.
اي والله.
So you can do the whole face with 1 ml, but the lips
إي-
with more.
هو ما دفع هو يصل
So I don't think I need to compete with you. I'm going home.
After 2 weeks, we should inject the same filler.
No.
We can
As a rule in injection, always under inject and then correct later. Because if you over inject and she's not happy, then you have to dissolve it. This is wasted money. It's like salt and food. You can always add more salt to your taste. But if you put too much salt, then you throw away the food.
And you're also losing the patient.
Of course. Always under inject. It's safer and it gives better results because when she comes back, like in Botox, you always under inject and then 2 weeks later she comes, you do your just fine touch-up. But what happens if you put too much Botox? What happens?
It's a complication.
And you don't have an antidote.
You need to wait.
So is it better to under inject or over inject?
Under inject.
Okay. Under inject?
No.
We should inject the same.
You are in this business for money.
أكيد.
Can't use different filler for one patient.
Why? if you have injected half the syringe and she kept the other half, why do you have to open a new one with new money?
No,
She still
different-
has her other half.
No, different brand.
If it doesn't happen, if it's not allowed for patients to leave with the product, or if she uses the whole 1 ml, is it possible, like after 2 weeks or after
Yes,
a month,
yes.
that she injects a different
Yes,
kind of
yes,
filler?
yes, yes it is.
No
Different type?
interaction. No
Because
interaction
it's
between-
it's mainly the same basis. It's hyaluronic acid, but you have to get something that's, almost. You can't get something like, for example, Juvederm has 23 milligram per ml. You can't use something like Novia Intense with 28 milligrams, and then you say it's two different things. You get something that's within the range, 23, 24 milligrams. So
No
it's
G
something
prime, no
that's,
problem.
no, it's moderate G prime.
Okay.
Because low G prime, you have some things like 6 milligrams per ml. You have some things like 9 and 15 milligrams. And you have something that go up to 32 milligrams.
So,
Good.
final question, because I'm intrigued now. When she takes the leftover filler, does she store it in the fridge, or is it stored at room temperature to keep it functioning?
You can put it either in the fridge, or you can put it at room temperature like this, but not exposed to
Under
the sun.
25.
After it's open, that's the...
Do you do Botox? Do you do Botox? Do you inject Botox? You only inject fillers? Do you inject Botox? Do you inject Botox? Okay. Doctor, you have your needle ready. The patient is lying down, and then all of a sudden she gets a phone call, and she says, "I'm sorry, doctor, I have to leave." It's okay, no problem. You put the Botox on the desk like this. You go home. You come back the next day. Oh my God, I forgot the Botox outside. Do you inject it or do you throw it away?
No.
We should do it.
Throw?
I'm asking you.
If the room temperature is in the room temperature or less than 20, I think it's okay.
Okay.
Because after I open it, I can put in the refrigerator.
Okay.
Before I talk about the allergen. Before in the freezer.
Okay.
If less than 20,
Now you took it out. You put saline solution. You did the dilution. You took out 1 ml to inject for your patient. Now it's fluid. And then you came to inject. She had to run away for something. You left it like this. You went home. You come back the next day. The syringe is outside like this.
I think
Do you throw it or do you use it?
I will inject it less than 20.
You will inject what?
The temperature less than 20,
Okay.
I can inject it.
and,
No.
Okay.
The Botox is highly fragile.
Yes. So,
What?
who will inject it? Who will throw it?
Throw.
Throw it. So, at a room temperature of 25 degrees, 25 degrees, this syringe, as long as it's not exposed to the sun, and the room temperature is 25, it can be outside the fridge for 5 days and you can still inject it. 5 days. Yeah, really.
So, one day my refrigerator door is open for 1 day. I threw out 5 bottles out. I am scared for injecting.
You're losing money. And in a room temperature of 30 degrees, you can store them up for 3 days. It goes for all kinds of Botox.
and at 25 for how many days?
5 days. And if it's exposed to the sun or temperatures above 30 degrees, 2 hours.
If something happen like this, my refrigerator door is open, no problem. It's in a pack, no open. Plus, you can use this. Thank you.
It's too late now. You threw them away. Right, so what instructions do you give to your clients after Botox injection?
Do not drop it.
Right?
Do not drop your injectable sites.
Right, so
Do
now
not
you've
go to the
done
sun.
you've done Botox,
Yeah.
and then your client leaves the office. Before leaving, you tell her some instructions.
Yeah.
She said, "Doctor, can I pray now?"
It's okay. They can pray.
Really?
Yeah.
Yeah, so she
From
can
this
go down
point
and pray.
on, Not like that. She should not touch the ground. This area should not be touching because there should be the dispersion of that.
Right, but she can bend down over and go to
Yeah,
the
it's
ground?
okay.
Okay.
It's okay.
Can I go home and sleep on my back?
Yeah,
Okay.
not on the face.
I always tell them 4 hours, don't bend for long time.
Yes.
Don't press the sides because of the.
Can I go to the gym?
No, I think no, 4 hours only.
Okay. You know, this is a true story. I had this client at my office. She had injected with the doctor, and the doctor told her, you know, don't look, don't bend yourself down, don't even look down with your eyes.
No,
That's right. So she was walking like this, you know, and she fell and she broke her leg. Okay. So let me tell you something. You can pray. You can sleep. You can do whatever you want. You can go to the gym. There are just 2 things you should avoid for 24 hours. You can touch your face. You can pray gently. You don't rub firmly. You're going to break down Botox particles. And you are not to be exposed to high temperatures like sauna or steam. That's it. So no foam rubbing and no overheat exposure. Otherwise, there are no restrictions. You can go to the gym, but if you're going to dry your sweat, just pat it gently with a towel. Don't go like this.
Bending no problem, yes.
bending for a long time is.
You know, she can do acrobatics. Try something with some of your relatives, maybe your sister, anyone. Inject 1/2 of her forehead. Okay, say inject the right side, and ask her to do this. Will the Botox go to the left side?
No, don't move this. No, we're afraid for if yeah, especially this area, this point here. If it is spread, maybe I will have
Doses.
Botox will not move because you're injecting
just
it into the
because
muscle.
of these points only. In retouch, when I inject higher or
No.
in this,
One more
that
time,
is okay.
in another time, I will give you the advanced Botox injections. You only get doses if you inject in one certain area. It's 1 centimeter or 1 finger breadth above the mid-pupillary line, and you have to be deep. If you inject superficially, there's no problem. But if you are deep in this 1 centimeter above the mid-pupillary line, here is where you get doses. Why do you get doses if you inject in this area?
Because the division of Botox to this muscle.
No, we don't know because of nose.
If you inject deeply, you're injecting indolence. So
Um,
why deeply? What do you inject deeply that causes doses?
It's a nerve.
Which muscle you mean?
Yeah, which muscle?
Orbicular.
Which muscle opens your eyelids when you wake up?
Orbicularis.
Orbicularis closes your eyes. Levator
Uh,
palpebral superiors. And they come from the frontalis muscle, but they are very deep over the bone. So if you inject this area deeply, you get doses. Otherwise, you don't. Now, what happens? Now, the same mid-pupillary line, lower eyelid, if you go medially inside. So, I got this mid-pupillary line, 1 centimeter above.
I get
Deep levator palpebral, you get ptosis. Now, mid-pupillary line again, lower eyelid, medial side. She'll say, doctor, when I look in a certain direction, I see everything as twos. I've got double vision, and I've got a bit of squint. What have you done?
We never inject Botox here. When we inject Botox here?
Inject Botox here. Don't pass the mid-pupillary line. What happens if you go medially? There's a muscle called the inferior oblique muscle. So when she's looking upwards and outwards, everything she sees, she's got diplopia or double vision. Inferior oblique muscle. It's that superficial. Okay. No problem. We'll go on with that. So a company like this is Bioxis company. They have a product called Cytoziala. I don't know if you've used it or not. It's one of the very good products. They got something called medium, deep wrinkles, and volume. So it gives you an idea where you're going to use those fillers. And if you take a look, they are all 25 milligrams. So the concentration is fixed. So what could be different?
Who is it?
Dr. Ariba, what could be different?
The
So if you,
concentration
is the same. So why is this volume and this is medium? So the company starts maneuvering in what? You got the same concentration, and it's probably the cross-linking or the particle size. You got from 150 to 250. Some companies give you an idea, you know, like deep lines, ultimate. You don't use YAD. You're familiar with it, right? Right. So KISS is for the lips, ultra deep. You know what we're talking about. And hyaluronic acid, this is something that's present in our body, in an average weight of 70 kilograms. There's about 15 grams of hyaluronic acid, that a third of which is synthesized and broken down each day, right? And its main function is to do two things. It's to bring water, so hydrate the area. As long as you have dryness, you have skin wrinkles. So it has to be hydrated. And water in the area will start helping collagen to develop, right? So now I ask you a question. I've heard a lot of people talking about, for example, doing radio frequency machines, fillers, Morpheus, things like this. And they say they will stimulate your collagen and elastin. Right? So you do this, you stimulate your collagen and elastin. So can you stimulate collagen and elastin both at the same time? Well, come on, Dr. Najm, I need fiery answers from you. You're working in the military of defense, right, in Bahrain?
Yeah. Well,
Do you have a degree? Like a lieutenant?
Yeah, a colonel.
A colonel?
But that's a civilian, so I'm
Right.
a civilian.
Right, so can you stimulate collagen and elastin both at the same time?
Probably.
Probably, right? No,
No.
no, you can't. Because they got completely different actions.
With the
They're
PRP
completely
also?
different, huh?
With the PRP, we cannot do that.
Now collagen, this is what gives you strength to the skin. So it's like, you know, this, if you have a band, a rubber band, when you pull like this, what prevents it from breaking is how much collagen you have. But when you leave, if it goes back to its original size, this is how much elastin you have. And the less elastin you have, that's why you see in older people, you know, you pull the lid like this and you let go, it doesn't go back. You have to keep on doing this, right? So, how much of elastin is present in our skin? A lot of propaganda is done over the social media. Stimulation of collagen and elastin content. How much elastin do we have in our skin? That's 2% of the total elastin in our body. Where is the main concentration of elastin, ya Dr. Taif? Right, so I'll give you a hint. You need something that when it recoils, it goes back to its original size. You don't want it to become floppy. So there's something working like this, and it has to go back to its original size. So the heart and the big vessels. Otherwise, if you don't have enough elastin and then the heart becomes,
How can you increase in elastin?
you can't increase.
Just we can collagen.
How can you make a red rose go white? It's red. Okay. And that's because it's a hydrating agent. Now you see we have pills, we have serums, we have lotions of hyaluronic acid. Now fillers approved by the FDA, which is the Food and Drug Administration, is divided into either temporary or permanent fillers. A permanent fillers, you got what we call the polymethyl methacrylate. There's no more silicone, Teflon, or acrylic, just polymethyl methacrylate. It has a trade name in the market, it's called Artifil. Okay? And it's only used in specific conditions, like its replacement of lost tissues. Like people, for instance, who have atrophy in their tendo Achilles or its cut, then you inject this area just to give a shape of it. Right? Hyaluronic acid fillers, they usually last from 6 to 12 months. Calcium hydroxyapatite up to 1.5 years, and polylactic acid will go up to 2 years. And I'll give you examples for all of these. Now, I've seen a lot of people inject calcium hydroxyapatite like Radiesse for skin rejuvenation, just superficially. And they say this is for skin rejuvenation. Now, this is very, very serious and dangerous. Calcium irritates your skin. And I've seen so many cases with nodules and granulomas. If you want to inject calcium hydroxyapatite, you'll be very deep. I don't care how much you try to dilute it. I don't care what you do. We always say it's for rejuvenation. It's for skin tightening. If you go with it superficially, inject it at your own risk. This is a very irritant substance. And you know what calcium hydroxyapatite was originally used for? Calcium hydroxyapatite, what was it originally used for? No? No, calcium hydroxyapatite, the substance, what was it used for originally? You know dentists? We put this in part of the bones to put screws upon it and then do
Artificial bone.
It's artificial bone.
The main content of the bone is the hydroxyapatite.
Yes. So that's why I say, if you go and inject it superficially, you're asking for trouble. And I see all the people on social media saying how they inject Radiesse superficially for skin rejuvenation. And this is extremely dangerous. Well, be careful. I've seen a lot of problems with it. And one time, she faced a problem, you'll be careful. I've had one client who had a reaction to it, and she got red spots from her head down to her toes, all over her body, front and back. And I've seen a lot of cases with permanent granulomas in the face. Do it deep.
If I inject deep, I can help the rejuvenation.
Yes, of course. Why don't you inject it deeply and then go rejuvenation, something like the skin boosters that are out there? It's much safer. If you can do a little bit of fat aspiration and prepare nanofats, it's even more and more, because you've got a lot of stem cells, fibroblasts, in fact. It's the best thing. Do you know how many, on average, how many fat cells do you have in our body? This is basic information. How many fat cells? I'm older than you are, and I can still remember this.
You are teaching this every day.
This is my first time to teach. So, on average, how many fat cells do we have in our body? Fat cells. And you know, the difference between a thin person and a fat person is the size, not the number. The size. So we almost have similar number of fat cells. A thin person will have a fat cell that big. A fat person will have a fat cell that big. But we have almost close numbers. Do you know, on average, average, how many fat cells does each individual have in our body? Take a guess. 1,000. 1 million. It's like an auction now. 1 million, huh? Alaona. All right, so on average, we have 4 billion fat cells. Okay? So you were close, 1,000? Very close. 4 billion.
I have a question. So the training of Radiesse tell me that filler of the hands with Radiesse should be superficially in the derms with the resistant. Do not go deeper than the derm. Is it right? In the hand.
Do you know how many companies have advertised for themselves wrongfully, and then after problems, don't care. Do you know, there was about 18 years ago, there was a product that was worldwide. It was called Dermadeep, and it was the best filler to be injected to give volume for the cheeks, and they said it stayed for 1.5 to 2 years. And then a year or 2 years later, I think in about 53 different countries, including the UK, Spain, France, Egypt, some parts of Africa, in Asia, in the States. And then women started developing granulomas. I've had this with 2 of my clients, and it appeared about 1.5 years later. And then we found out that there were so many women around the world who got affected from this product. The company was sued for 70 billion pounds. So let the companies advertise whatever the way they want. You just do the right thing. There were so many drugs in the market that were FDA approved. And then a few years later, they take them out of the market again, right? Yeah. Don't listen to what companies tell you. Right, so scientific names for polymethylmethacrylate, which is a permafil, like I said, it's called Artifil, this is the brand name. You got calcium hydroxyapatite like Radius and like Novia, and Novia has a very small percentage of calcium hydroxyapatite, 0.2%. You know, Radius used to have 30% calcium hydroxyapatite. I think that they put it down to 2% or 3%. Novia still has 0.2. And sometimes I'd use Novia with 0.2% calcium hydroxyapatite, and I still go deep and check with it. You got polylactic acid like Sculptra and like Elancé. And Elancé is a French product. I think you're familiar with Sculptra here, right? Elancé is much better because it's ready-made, it's a gel just like all the other fillers. And then you have hyaluronic acid fillers, so many brands there like Restylane, Juvederm, Hyalform, whatever. And then you've got collagen fillers, which are very rarely used nowadays, like Z-Derm or Z-Plast, mainly used in Switzerland. These are the areas, Scandinavian countries, they use them. And we used to get collagen from 3 different sources, not hyaluronic acid, collagen. We used to obtain collagen from 3 different sources, which are? How did we get collagen a long time ago?
Collagen for which purpose?
For injecting. So, see, now we get hyaluronic, so we have, we're talking about injections now. So how do we get collagen? It's not for the purpose of selling them. I don't want to make money, I'm not a trader. We're talking about this now. So, remember there was an animal source called bovine from cattle, porcine from pig, and human. Either from fresh cadaver, the same tissue typing, or from a person itself. Now the problem with that is it caused a severe hypersensitivity reaction. You had to test for sensitivity, and it takes a long time to prepare. Its effect will last 1 to 3 months only. And then we also had cross-infection from human beings or from cattle. Brucella, remember Brucella? Brucellosis.
Yes.
Okay, so now we come to the fun part. If you take a look at this, so what has changed? And I'll tell you as a surgeon, because I do operations and I do cut the skin and see what's underneath, that the changes occur at 3 different levels. They occur at the bony level, they occur at the soft tissue level, and they occur at the skin level. So, what happens is bone becomes resorbed. Take a look, for example, at our zygoma and maxilla, they become resorbed. And this is what all the ligaments, our muscles and subcutaneous fat are resting on. So when it's resorbed, everything just starts going down as well. And if you take a look at the skull of a young person and an old person, see how everything starts to shrink? Because of the stores, thickness of the mandible. That's why a lot of our, if you see older members of a family, start to have loose teeth when they grow up. Now, this is the important part. Now, we have what we call the malar fat pad, and this is an essential landmark for injecting. And if you can't understand this, you will never be a successful person as a person who injects. This is, you have to learn this off by heart. Okay. So this is the malar fat pad, and this is just a bigger image of it. You can further divide it into several parts, but we'll take it as a whole. And what happens is we have some ligaments here without going into details of the names of the ligaments, like the orbitocutaneous and zygomaticocutaneous ligaments, but they're holding the fats up like this. And when they start going down by gravity, by aging, by depletion of stores, they don't drop down like this. Because if you had your fat pad dropping down, it would look like this, as if you had food in your mouth. But it goes downwards and inwards. So the medial part of this triangle will go downwards and push, causing exaggeration of the nasolabial folds. Okay. And can you see clearly? Put these down. So then these lines become more exaggerated because the medial part of the fat pad has pushed it. And then the upper part, which will give me contouring of the infraorbital region, now that it has sunken down, you get what we call the tear trough deformity. Okay? And what they used to teach us a long time ago was, if you get a person like this, we would go with a needle or with a cannula, and you go along the line and you inject the nasolabial folds, right?
No.
So you have to lift this up back in position. Okay? This is the way I was taught about 28 years ago, 29 years ago. So you need to put this back, put the volume back where it should be. Sometimes you don't even need to inject the nasolabial folds. Okay? And I wonder how you're going to do this and all the face with 1 ml. And you want to put more than 2 ml in the lips. So all this, all the, listen, doctor, let me tell you something. You are the leader in your office. The patient does not guide you. You guide them.
بس ده فاهمك ده انا بقول لك شلون
مش عاجب يمشي يروح لدكتور غيري. These are my rules. If you don't like them, go and see another doctor. I don't care about your money. I care about my reputation and my success. I never let the patient guide me. I guide them.
بس ده شكل العيادات
انتوا في العراق؟ انا اعمل اللي انت عايزه. Okay, so this is the malar fat part I was talking about. See, you can further divide them into a medial part, a middle part, and a lateral part. And see, this is just underneath the skin. So you take the skin flap off, and this is superficial. So medial, middle, and lateral. But then you can take the superficial fat compartments out, and then you will see the deep fat compartments down, along with the muscles and nerves. These are deep. And that's why I said there are superficial and there are deep compartments of the face. And the superficial ones are what become ptotic, they sag down, and the deep ones become more atrophic. And that's why I would always go deep, so I would restore volume down, and at the same time, if you're injecting filler in between two soft planes in the middle, the filler will go up and down uniformly. But what happens if you go deep down to the bone? Then when you inject, the only way the filler can go is up. It can't push through the bone. So it goes upwards. So not only do you restore volume, but from the pushing up, it also brings some tension to the superficial fat compartments. Okay? Right, so the OG curve that we talked about. Now, have you seen this on the walls? Sometimes you see them on ceilings of walls. Right, this is an architectural shape, that شكل هندسي. So we used to take in physics a long time ago, if something is curved to the outside, it's called convexity. And if it's to the inside, it's called concavity. So convex and concave. So the OG curve is also known as a serpentine. With the serpent, snake, it's called the S. Sigmoid. Mirror C. It's like, one C here, and another C. So they call it the mirror C. Whatever you want to call it, it's just the OG curve. So it should start with a convexity and then end with a concavity. And you can only see this in women in about a 20-degree oblique view. Right? So if you have convexity first, then concavity, with one point here. Let me try this. I don't know if this will work or not. Aha. So if you have convexity here, then concavity, this is what we call the cyma recta. If it's the opposite, if you have concavity first, then convexity, it's called cyma reversa. So it's the reversal. Right, so let's apply this now. So convexity, then concavity. Take a look at this, see? So from a 20-degree angle, you got convexity, then concavity. This is a full cheek. And as you grow older, what happens is this curve becomes lost more and more. So it becomes a flat line, and then when everything folds down and you have jowling up like this, then this is convex and this is concave, and then you got the cyma reversa. So now fillers are not an option alone. You might need to do thread lifting, or you might need to do surgery. So this is all under the name of assessment. You are assessing your case, right? So this is, now let's take a look at this, see? She's starting to have a flat OG curve. You're starting to have a flat OG curve, and this is how you assess it after injection. You let her take a look at this. You say, do you need more, or are you satisfied this way? So the first thing was you had the malar fat pad and other tissues sagging down. But then we also have volume loss.
Yes.
So things, they not only fall down, but they become atrophic. So you need to fill, you might need to fill and lift. And never forget that the face is divided into 3 parts. The upper third, up to the eyebrows, lower third, a middle third to the nose, and lower third to the chin. Because you're almost always assessing things. And then there is something now that you can read in a lot of new papers, articles, and in conferences you hear what sometimes they say a GIR or a HIR, H-I-R, G-I-R. Have you heard of that before? Right, so what's a G-I-R and what's an H-I-R? Have you heard about it before? Huh? Me neither. I don't know. Right. So a GIR is what we call a groove in the infraorbital region. And an HIR is hollowness in the infraorbital region. So a groove in the infraorbital region is just another name for the nasojugular groove or tail trough deformity. But they called it like this because there is special anatomical changes that happen. Right? And we don't want to go into so much details, but when you have infraorbital hollowness, because there is malar bone resorption, then you start having the hollowness. So this also gives you an idea. Do you want to inject a little bit superficially? Do you want to do some, say, lifting like blepharoplasty? Or is it just hollowness? You want to replace volume, bone resorption? So you have to analyze to see what you're going to do. So this is an example of a groove in the infraorbital region. And then you don't have this groove, you just have a hollow area. So this is hollowness in the infraorbital region. And you can have both together. You can have groove and the area is just sunken down. You can have both hollowness. And so I probably do something like filler injection here. I do fat injection here. And in a case like this, I'd probably maybe even do blepharoplasty as well. Okay, so I love this part. Now, you all have experiences with fillers.
Yes.
Okay. And I always want to tell you that every time I give this course, there is a message I want to send out to doctors. So I'm going to ask you one by one, not only as a doctor, but as a female. Women tend to look at each other, what has she done? And men look at women as well. So we normally don't look at their faces, but we're still going to look. So as a doctor and as a woman, let's find out what these clients I have done for. And then by the end of this presentation, there will be a message I want to tell you, and you'll probably understand this message. So, Dr. Ines, is that right? Dr. Ines. Right. Let's go. So this is my patient, I did something for her, and then this is the before and after. So this is before and this is after.
Okay.
What do you think? No, she's your friend. Don't pretend you're a doctor. She's your neighbor. Tell her, come here.
I think.
You did.
No, I think he didn't do anything. Just she go to sleep.
She go to sleep. So I went home with her, and she went to sleep, and I took a picture when her lying
Because
on
I
bed.
have experience with patient. You have dark and like
What?
that.
She's got the same clothes on.
Okay.
And so I told her to go to sleep and come back so I can take a photo. She goes to sleep وتصور نفسها. Come on, tell me some answers that are more medical. I'll come back to you again. So before was after sleeping and after is when she woke up.
كان عندها النيزوليبرين بعدين عملنا okay speaking English.
So I injected the nasolabials. What else?
No, not correct here. You correct the cheeks.
Okay.
Here. And
So what do you think I did for her? You don't have to
facelifting with filler.
Facelifting with fillers, maybe with threads, right?
I think filler.
Fillers. You think so?
So there is only light difference.
Well,
I think just
right,
like
listen.
Just a light difference.
So this one on the left side, I had my mobile phone. I put flash on. Second one, flash off. That's it. So message number one, light effects do make a difference. Okay.
Picture?
Dr. Ariba.
Yeah, sir. It's a makeup without it.
Thank you very much. Dr. Ariba, this was easy. Now tell me this one. Look carefully.
Nothing, just the dress is different. It's the same. It's the same, sir. Just the dress is different.
You're quite smart, you know that? You're quite smart. Huh?
So I'm just saying, but I'm.
A lot of people fall for it. Huh?
No, I'm not sure.
Okay, tell me what you think.
I think it's a difference in the angle of the photo.
It's just a difference in the background. This was in her room. We were getting ready for the operation. This is down at the operating room.
No,
The background.
For the background.
I think.
And I tell them this. 5 months ago, I was in a conference in Madrid, and I had, it was an honor to meet the executive photographer of a magazine called Vogue, and he said, always take pictures of your clients with a light background, not a dark background. Makes you see things better in a better way. Nothing. Just the background. See, white background, dark background.
Because of the background.
So you see things and
Yes, exactly.
no, because some other things have changed. They give you a false perception. You see things that are not there.
so hair color is different.
Doctor, someone told you about me.
So it's a person.
Doctor,
Yes. I think the nose has been done.
okay. Maybe the chin.
Yeah, there's some pigmentation.
Okay.
No, the hair dye. The hair dye.
The hair color.
Yeah.
Hair color.
Hair color.
Just the haircut. Okay. Don't
Okay.
answer. Don't answer. You're smart. What is what? Huh?
I know.
The model of hair.
I know.
The model of hair. The hairstyle.
Color of the
Yes.
Uh-huh.
No, I know.
color of the lips.
changed the color of the lips. But it gave you the impression of other things, right?
With facial expression.
The foot is more closed in this left side, more closed. Eyelashes. Oh, no.
Hard, okay, more close. More close. This is for you,
Yeah.
because you're smart. And when I used to, when I had my training courses in London, there was a very famous doctor there, David Rosen, and he would say, if you do a good job, then someone will see your client and say, oh, you did fillers for your cheeks, you did, so they look nice. So they've spotted that. So you've done a good job. But to do a very good job is they go over to your client and say,
What do you?
you look nice,
Yes,
what have you done? They can't spot it, then you've done a very good job. So Dr. Ariba, because she's very smart, can you spot what I've done?
Sir, I'm not smart. I'm just
Yes, you are. Yes, you are. And have confidence in yourself. You are smart.
Sir,
This is
I
not a
don't-
compliment. Because the ones you have answered, no one has ever answered before.
I'm just seeing it, sir.
Well, they
Because
haven't
I-
seen it.
Because sir,
Maybe
many
they need
times
to
it happens that
many-
my nurses are taking the pictures and they are not taking correctly, so it happens.
No, it's because you take care of details, which is essential. Now, all I've done for her
Usually
was
patients
treated.
are coming after that and they are claiming that they don't have anything, so we are taking the pictures and we are comparing. So
But you are taking care of details.
yeah,
Some other people don't take care of details.
sir, here I cannot comment.
I just injected this malar.
Cheeks.
So I lifted just the malar fat pad and I treated a little bit the tear trough area.
How much ml do you use?
0.5, 0.5. 1 ml. Only here, not for the whole face. 2 ml, 3 ml في اللبس والوش كله 1 ml يا مفتري. اوكي. دكتورة مي.
Lip filler and chin.
Lip filler, okay.
Chin filler.
Okay.
Chin also.
So I did a little bit of lip fillers. I did her chin and I did her jawline. Okay. No, I didn't do anything for the cheeks. But they look as if they have been injected.
Yes.
But I didn't do anything for them. Dr. Ilham, just tell me what you think I did. Sorry? Thread lift. You know, do you use cannulas for injection?
Yes.
Okay. The bigger size cannulas, like use 22, 23 gauge, 25 gauge. I get the 16 gauge, it's thicker. And I get a 5 cc syringe. And I stick it inside there, pull the plunger, negative pressure, and I go like this, I'm sculpting the fat. It's like liposuction of the facial fat. So I just sculpted the jowls. I didn't do anything with the chin. And it already looks like this.
No filler in the chin.
I just took fats from here, so now it's more or less contoured together, symmetrical.
All you did was
Liposuction, شفاف الدهون liposuction.
It's red
she
and
looks younger.
I just sculpted the jowls.
Did you remove
Huh?
the fat or you just put
Yes.
the cannula in?
No, I removed the fat. That's why I said a 5 cc syringe, negative suction. So when I do this, the fat comes out in the syringe. That's it.
tumescent or dry method?
Huh?
The tumescent or dry
Of
method?
course. Tumescent has to be with anesthesia. It's going to be very painful. Yes. Dr. Najm.
Yeah.
Yeah.
The one on the left is a disaster. It's too much filler on the left side actually. I
Okay.
don't know. I mean the face is too full on the left.
Yeah, maybe also closer.
The distance.
No, what I did Botox for her eyelids. Do you know that I inject Botox in the eyelids? You know that?
Yes.
In the
lower
eyelids.
eyelid?
Yeah, I do.
The lower eyelid?
Upper
For the
eyelid.
creams?
Upper eyelid. So you inject just close to the eyelashes. Because the levator stops at the crease, about 1 centimeter away. So you inject orbicularis just in the eyelashes. And what happens is, people who have what we call the droopy eyes, like this, you inject and their eyes open. So this is Botox just to increase the width of the eye.
So instead of the blepharoplasty, we can do that. No?
She's not candidate for blepharoplasty. She doesn't have excess skin, but she's got droopy eyes. Like you call them the tired eyes. She doesn't have excess skin. Maybe she has an overaction of the orbicularis muscle, so close the eye. So you relax the muscle. What happens? The eyes become more open. Okay? Okay. يلا دكتور باباك. Right? Dr. Babak. I'll help you.
Just a smile.
Just a smile? No.
Liposuction?
You know, she was, she's a lady that has dentures. She takes them out and she puts them back in. Teeth, you know, dentures, طقم أسنان. So this is without the dentures, so everything is sunken down. Then I told her, put your dentures back in. She looks like that. So if you want to do any fillers around this area, if she's doing any work with her teeth, let her finish it. Then come over to you, because this is the building blocks.
Thank you.
It's okay. دكتور طايف.
The jawline.
The jawline, perfect. See, I'm so happy because there's something that's going on, but then your vision goes somewhere else.
Yes, I think you remove the fat from her tongue.
The fat from her mouth. And she's not that fat.
Posture.
Have you ever heard of someone having liposuction from the neck?
أيوة.
I've never heard.
حتى اللايبولايسيس بيتعمل في السعودية هنا في
The posture of the
كيف بيعمل البودي كنترول
You never go up here. Yeah, you can go the back rolls, the love handle. You don't, oh, what hand? We're not a camel. No. This is relaxing the trapezius muscle. This is what we call the traptox. Botox here. So what happens is she got a seemingly longer neck. And then when you saw this, like everyone else, you said, the jawline looks better. No, it's just, trapezius does this. And without knowing it, we're always like this when you're stiff, when you're on the desk. When this relaxes,
يعني حالنا بوتوكس هنا؟
في الترابيزيوس.
طيب أنا كويس شوية.
لا you're not close at all.
عشان
يعني حقنا بوتوكس في الترابيزيوس شفطة قفاها يعني.
لأنه النك بيجت longer.
واحدة شغل بني آدمين والتانية شغل جمال، ده ما لهوش علاقة خالص ببعض. Okay. Now this is easy. Nose threads. Just lifting the tip and correcting the hump. Yeah, I can do threads. I can do threads and some fillers here. And then this is the final one. Look closely. I'm helping you. Yeah, Dr. Ilham. Facelift. Okay. Okay. Oh, look. Hair transplant. So anyway, so then you have what we call wrinkles, fine wrinkles. We have moderate wrinkles called furrows, and we have deep wrinkles, sometimes called folds. All right, so you have a wrinkle, a furrow, and a fold. So I might do some skin rejuvenation here. I might do some machines. I'd go for skin, do maybe thread lifting. When I find a case like this, don't waste her time and your time with trying to do filler injections. Just send her to a surgeon to do a face test.
So for this one, HIFU is not effective for pores.
Do you know that what is very strong now is a machine called the Morpheus?
Yeah.
Morpheus is very strong. Have you seen lately the latest researches, 2 years after using Morpheus, what the problems are? Now Morpheus has a deep penetrating power, up to 8 millimeters. And what happens is, it just dissolves the fat of the face. And then people who have been doing Morpheus, 2 years later, 3 years later, they come in what we call the Gonti look. No more fat. And they look old, and then they have to do fat injection. So Morpheus will have a lot of problems, but it's going to show up gradually. Okay, so because we said folds and furrows, then according to how deep your line is, if you need to go deep enough, these angles of injection do make a big difference. The angles of injection do make a big difference. So I go almost superficial like this when I'm doing a superficial injection, or I go perpendicularly like this if I'm doing a deep injection, and I have to know the depth of level that I'm injecting. I shifted to cannulas now for a very long time. I use needles in very specific areas that I'll tell you about, but very specific areas. Otherwise, I'm always with a cannula. And these are, I don't know if you have, who's living here in the Emirates, you have these brands, cannulas. Now this is one of the best, soft fill and Silcan. This is a French company, this is an English company, and they are all they are companies that only do fillers, only do cannulas for fillers. And of course, you know the injection techniques. We have what we call the linear threading technique. You go inside with a cannula and you put one line that's linear, like a long time ago. You put your cannula and you start injecting retrograde, so this is called linear threading technique. But you also have what we call the fanning technique. If you want to get an area, say example, you go inside here and you do a fan like this to fill the whole cheek. And we have what we call the cross hatching. You would go in one direction, then the opposite direction to simulate a collagen network. We have what we call the fern pattern. Sometimes they call it the zipper technique. So you inject some lines and then lines opposite to them, like this, so that they complete each other. So it's like called a fern pattern. You have the bolus techniques. You put a bolus next to a bolus and so on and so on. Then you start molding them together. Or you, for mesotherapy, you use what we call the multi-puncture technique, so just for skin rejuvenation. And of course, complications of fillers that include some, especially when injecting the tear trough area. I didn't ask you for anything. So, especially injecting the tear trough area, sometimes you get people with persistent swelling. And here is one of the areas where problems happen, because if you don't know where you are directing your needles, especially sharp needles, more than cannulas, if you don't know the proper plane or lever you're injecting, and direction you're going, and the product you're injecting, then you're doing a lot of trouble. Because lymphatics of the lower eyelid are usually perpendicular. You know, they go like this, and they all go towards the preauricular lymph nodes, follow the vessel. So I see a lot of people when they inject the tear trough area, they come from the side and they go like this. So you are traversing, you are cutting the lymphatics. And if you are in the wrong plane, you get persistent swelling later on. Other things are, if you have fat bulges and you don't inject properly, you can inject beneath those fat pockets, or the fat pads, they become more prominent. Or if you inject a filler that's too superficial with the light reflection, you get what we call the Tyndall effect. You've heard about that? You've seen it sometimes? What I talked about, low molecular weights in certain areas, you get what we call the filler migration, especially around the lips. That's why when I inject fillers in the lips, I never go over the white roll or the white line like they used to teach us a long time ago to put contour. I go inside the lip and do my contouring. Because if you do it on the outside, you get a filler migration. It looks awful. And of course, granulomas. And granuloma is, for me, only caused by one reason. Either the product itself, maybe it's expired, so it's a severe foreign body that the body attacks, forms a granuloma. But the main cause of a granuloma is infection. If you don't sterilize the face properly and you introduce infection, then you get a granuloma. Sometimes overfilling, you get all sorts of things, duck lips, witch chin, chipmunk cheeks, call them whatever you want. Okay. So if you have a problem, then you go for hyalase. And as a piece of advice, never use hyalase except in emergency situations. If a patient comes over to my clinic and says, "Doctor, I did fillers and I don't like the way I look," I don't care. I'm not going to dissolve them. They're too big, dissolve them. I say no. Because two things happen when you inject hyaluronidase or hyalase. One is you have to do a sensitivity test, because sometimes you do get a reaction. The other thing is, it not only dissolves the hyaluronic acid filler, it will dissolve the normal tissues and collagen present. So I only use it for emergencies. So if you are forced in an emergency case, which I mean a vascular occlusion, how do you dilute hyalase? Aren't you injecting fillers? You should be prepared for an emergency. You should have hyalase in your fridge, and you should be able to know how to dilute it and use it. I've done this 3 times in my life, and not because of me. And alhamdulillah so far. Someone does something, they call me, it's an emergency, come over to my clinic quickly, try to save the condition. Okay? So how to dilute hyalase?
5,000 with 10 ml.
There's no 5,000.
This is 1,500.
1,500, 1,500.
You use 10 ml to do the test,
Okay.
and with 5 ml to inject. For each 1 ml of filler, I inject 1 ml
So, 10 ml of saline ampoules is prepared. You take out 1 ml and you put it in the 1,500 units of the vial. Okay? You shake it properly, and then this is added back and mixed with the 10 ml. So now, 1,500 units are present in 10 ml. So each 1 ml will have 150 units of hyalase or hyaluronidase, right? It's always advisable to use the 0.5 ml syringes. The 0.5 ml syringes. This will contain 75 units of hyalase. And you don't say 1 ml of hyalase for 1 ml of filler. I've seen people who have injected 12 or 15.
Yes, I mean by session. This is the dose we do every 2 hours if there is occlusion. If I do in my clinic classes lips for patient not like their lips, every 1 week. If she did
No. Let her do some hot foments and squeeze it through. Don't use, because she will come back in about a few months or 1 year later with very thin lips. Don't do it unless it's an occlusion. But if she doesn't like it, you don't care. Don't like it. Put some hot foments on your lips and sleep over them. Put hot foments, put your face on the pillow and sleep all night like this. She will wake up in the morning with no fillers. I can guarantee you this. Okay. So now, use the 0.5 ml, and then how do you inject? So retrobulbar hyalase, this is the most important thing. It's if you are afraid of blindness. This is the most important, because there are reported cases of blindness with fillers. So you inject a dose of 250 units up to 3 times with 2 hours interval. Okay. So you inject like 2.5, that's 4.5 series. So the 1 ml will have 150. Okay. So it's about 1.5 ml. So 1 3/4 ml. Yes. 1 3/4. Yes. 1 3/4. Up 250 units every 2 hours, but up to 3 times. Okay.
But, doctor,
Yes.
we should do it by the ophthalmologist, right?
No. This is, now I said, I did this 3 times in my life. One of them, I did a retrobulbar injection. And I'll show you how to do it now. Okay? So you get 500 milligrams of acetazolamide. This reduces the intraocular pressure and increases the retinal blood flow. And you can also give mannitol, decreases edema at this area. So this is all to save the eyes. Okay? Because if she's got a gangrenous part of her lips, we can always treat that, no problem. But you can't treat blindness once it happens.
The blindness complaint or the ocular pain complaint, will it appear immediately after injection, like before she makes contact?
Sometimes you do it, sometimes you get it within a few hours. Okay?
So this 250 units and the 300 units are done together, or this is another option?
Which one?
You've mentioned retrobulbar hyaluronidase.
Yes, and also 300 units separately, supraorbital and infraorbital foramen.
These 3 are done at the same time?
Yes, this is all to save the eye. Now, each one of you, put your fingers on your lower eye. This is the lower orbital margin. And then start going laterally outside until you feel a notch. Can you feel a notch? No, you have to be inside though, not from the outside. Almost touching your globe. See? And then there's a notch here. Who can't feel it, tell me. I'll explain how to feel it. Look up. Look up. This is how to feel it properly. Okay? It's notch. Look up. No. Here. This is the most important. Look up. Yes. Perfect. It is super. Did you feel it? Look up. Look up. Yes. No, just a little depression. You can feel it here better. Okay? This is the supraorbital. They're close to each other. Supratrochlear usually is an ostium. It's a small opening, not a notch. You don't feel it.
Just me.
Yes, of course. feel a small indentation in the bone.
An upper?
Yes.
Upper one?
You should test it, Hialas, before.
Yes, you have to.
If the patient reacted to Hialas, what should?
Leave the country. Run to the airport because she will be blind.
The upper one?
No, if she is, you have to save her with Hyalase. So you inject it and you keep corticosteroids and adrenaline next to you.
It's important.
Yes.
We inject on
If
the
she
hand.
dies from the Hyalase, then
It doesn't help.
it's not a problem. She died from the drug. She didn't get blind. You are safe.
How many units we should put for the testing? How many units on the hand?
Just a small amount. Just a few drops intradermally, and you do about a 2 centimeter circle like this. Here, in the medial part of the forearm, you draw like a coin, and you put just a few ml here, just a few drops,
Just 10 minutes we wait for that?
and you wait for about 10 to 15 minutes, and you see if there is a wheel reaction on it.
So what happens to the eye in those 10 minutes?
You're praying. Okay.
This doctor?
So-
This supraorbitals, just how much?
Feel it from the inside. Okay. So what happens is you pull this downwards, needle, and then after the needle you go in with a cannula because it's blunt tipped. Through the infraorbital notch here, the lateral orbital notch, this one, the lateral orbital notch, right? And with your finger, you put your finger like this and you push the eye globe upwards.
Doing a retrobulbar injection.
So,
Using my left hand to push the eye up.
so he's pushing the eye up, this is the notch,
2/3 of the
and then you go in like this.
first down straight through.
Then, after you pierce the septum, the orbital septum, you direct it upwards again because you want to go behind to the vessels in the globe.
9 feet into the retrobulbar space, injecting about 4 cc's behind the eye. Now I'm going to withdraw this 23 gauge 1 needle, just in the area of your vicularis.
Conjugate,
So, you can use a needle. If you're confident, you can use a cannula, small gauge, like 25 gauge. You don't want something very thick. So you feel the notch, you're inside, you push the eye globe upwards, you go perpendicularly, then when you pierce the orbital septum, what you do is you change direction because the vessels, so you're going the notch through here. The vessels are up here. So you're going like this, you're piercing the fascia, you're pushing the upwards, then you change direction of your needle to go and inject around the vessels. Let's see that again. Here you go. So now he's feeling the notch, see? Pushes the globe upwards, he goes perpendicularly,
2/3 of the lower lid, I'm making the injection first down straight through.
then see how he changes direction? Upwards.
Making sure I'm in free space. I'll withdraw.
Red.
And I'll inject this fixture to the key, 9 feet into the retrobulbar space. Injecting about 4 cc's behind the eye. Now I'm going to withdraw this 23 gauge 1 needle, just in the area of your vicularis.
Okay. So there are general rules for avoiding a vessel occlusion. What you do is, first of all, know your anatomy very well off. Palpate for the vessels. Use a Doppler to get the vessels. They do it nowadays a lot. Say injection with ultrasound guided or Doppler guided. Right. So don't inject large volumes. Always use smaller volumes and add as you go. It's much safer. Okay.
excuse me, maybe this occlusion happened with normal fat or no?
Yes. It can happen with anything. Okay. Look for signs of blanching, severe pain, discomfort. So if you're injecting slowly, you're injecting in small amounts. I know where my anatomy is, and I've aspirated first before I inject. I always tell them this, when you put especially the needle, just aspirate. But I see people do this. They go in with the cannula, they do this, no blood, they inject. Fillers have high viscosity. You should count at least from 7 to 10. So you pull the plunger and you go 1001, 1002, or 1, 2, 3, up to 10. Dr. Marwa, you were in one session before, and they put the needle inside of the cannula and they aspirated. And by the count of 9, what happened? Blood came out. So if you do this, no blood, inject? No. There is big viscosity of the filler. Wait, try to add, and count to 10. She was with me, Dr. Marwa, it's my younger sister. She's been helping me at the academy for a long time now. And she was with a group training them, and this is exactly what happened. They were counting, there's nothing. She said, wait. And by the count of 9, the blood started coming out. So you aspirate, you count to 10, know your anatomy, palpate for vessels, do whatever you want, inject slowly. The key is very slow injection, because if there is severe pain all of a sudden, if there are any color changes, sometimes you can see them immediately if it's a vascular occlusion, if it's an arterial occlusion. It's delayed if it's a venous occlusion, maybe 2-3 days. And the difference is, in an arterial occlusion, the area goes blanche. And in a venous occlusion, the area goes mottled or dark. Yes. Right? And usually venous occurs after a few days, arterial will occur immediately. That's why, if there's severe pain, and if you're injecting slowly, and you had all these precautions, if one drop, this will not occlude the artery. And you don't have to inject fillers straight into the artery. If, for example, in a compressed area, like facial artery in the piriform fossa, and you want to inject the nasolabial folds, I see people put a big bolus here. So this might compress the vessel, and this is what we call, it's like, like bed sores. This is compression necrosis. And then the wall of the blood vessel becomes eaten up by the hyaluronic acid and by the compression, and then the product will go inside the artery. So it not only has to be injection directly into the artery, it can be because of the pressure necrosis that happened from a big amount in a confined space. That's why always under inject and add more.
What do you mean by small amount of filler per bolus, and what do you mean by a big amount of per injection?
I can't tell you numbers because each one has different facial dimensions. If you come to my office and say, I want to do some cheek volumization, will I inject you the same amount? For instance, if I inject Dr. Ilham or Dr. Najm, you have different faces.
So, like, on average, like a safe amount?
Well, I'll tell you something that might be good to be your basics for how much you're going to inject. Ask her how much money she has. So if she can afford 2 syringes, then distribute them over 2 syringes, and you can adjust the amount. If she said you're in trouble, if she says, I don't care, do as many injections as you want.
Sorry, no, I meant for safety, to avoid a vascular occlusion. Like, say
There is nothing called how much. Some faces can withstand. I've seen people inject 1 ml, a whole ml in the piriform fossa here, and nothing happened. And I've seen problems with 0.3 or 0.4 ml. It's just you inject, if there is nothing wrong, massage and take a look and evaluate. Do I need to add more or don't I need to add more? If you don't need to add more, then go to a different area. Okay? But don't try to memorize it in numbers or figures. Medicine is much, much bigger than to put in a frame. And then give her about 2 weeks apart, and then do another session if you need to open. So you don't want her coming over to you like this with necrosis of her nasolabial folds. You don't want her coming over with necrosis of the lips. And let me tell you something. There was a Dutch guy, Tom van Eyck. It's called Tom van Eyck. Where do Dutch come from? Germany. Everyone says Germany.
Holland.
Dutch is Holland. Deutsch is Germany. Right, so Dutch guy is called Tom van Eyck. He was the first one to invent a certain injection technique of the lips. He's called lip tenting, which lines superficially. And then there's this famous, may God be with her, she's sick with cancer, inshallah she'll get better, Julie Horn. She's very famous, Julie Horn, for lip injections. She was a student of Tom van Eyck, and then she took this technique and she tried to develop it a little bit more. And she depended on injecting vertically like this, just underneath the skin and above the orbicularis oris muscle. So she would go like this, for instance, and she would inject just vertically, small, very, very little threads parallel to each other. That's why I don't use more than 0.4. And they always told us that the vessels are deep behind the orbicularis muscle. Yeah, it's in about 80% of people. But in 10%, the vessels are passing through the muscles. And in another 10% of people, the vessels are anterior to the muscle. They are that superficial. So be very careful when you're injecting. Again, look for any signs of pain, look for any signs of color changes. And it's very difficult to assess with pain because you're usually anesthetized. Your patients are on anesthetics. So look for color changes. And because the superior and inferior labial arteries run across like this, injecting perpendicular, it's less liable to inject into the vessel. And I always give them this example. If you see someone going to the operating room, they have veins like this. They put a cannula for the IV solutions, right? Do you put a cannula like this or do you put it across? So injecting across a vessel, it's much safer not to inject into the vessel. Because I've also seen people inject this way with needles or with cannulas. So they are injecting in the direction of the arteries, and you can very easily, without knowing, put your cannula straight into the artery as if you're cannulizing a vein before an operation, and disaster occurs. Okay. Remember in anatomy they used to tell us there is the external carotid and internal carotid arteries? Remember that? External carotid artery system, internal carotid artery system. Well, they meet at 2 points in the face. And those 2 points are where fillers you inject can cross to from the external to the internal carotid artery system to the ophthalmic artery and cause blindness. Okay? We will talk about those 2 points after you have your 10 minutes of break. So as not to get too much information at one time.